So can I share my screen now?
Absolutely, yes.
Okay, can you see my screen now? No,
It's coming up.
okay. So today I will present 3 cases about melanocytic lesions. And first, I want to thank you, Open Team, to give me the opportunity to present my cases. And especially want to thank Dr. Asabechi. She's not here today, but she is mentoring me and providing these cases along with the detailed instruction. So, okay, let's get started. So our first case about a 5-year-old boy with a pink tumor on his right cheek. So we see the lesion here. It's a dome shape, smooth surface. And here we have the desmoscopy review a non-specific regular pseudo network with a granular appearance. We can see the pseudo network in the lesions. Under the microscope, we see the well circumscribed, symmetrical, and dome-shaped lesions involving the epidermis and the dermis. The epidermis is slightly acanthotic. We see here is acanthotic. And the lesions is composed of nests. They have many nests and fascicle of cells extending downward into the dermis. In the higher views, we see the lesion is sharply circumscribed and so nests and fascicle of cells. The cells extend from the epidermis into the dermis in a vertical. We call it the raining down patterns. The nests are separated by the cleft-like spaces. And again, here we see the epidermis above is slightly thickened. You can see here and over here. In higher views, we can see clearly the acanthosis with the elongated ridges. There are the large nests of the epithelioid and spindle-shaped melanocytes at the dermo-epidermal junctions and extended into the dermis. There are the melanin pigment present in the dermis. We see the coarse melanin over here. The dermal components show maturation with depth. Here we see the cells appear smaller and less pigmented, deeper in the dermis compared to above. This one we can see here the large epithelioid melanocytes with abundant cytoplasm. Some cells contain prominent coarse melanin pigment, giving it a dark brown appearance. The nests are relatively cohesive and is located in the superficial dermis. We can see no obvious mitosis figures or necrosis in this field. So this is the bottom of the lesions. The melanocytes nest in the dermis here is the smaller and less pigmented compared to above. And this is the evidence of maturations with depth. So the cells are become smaller, more spindle and less cytological atypical towards the base. There are no abnormal mitosis activities or necrosis. And we see here is the collagen bundles surrounding and no invasive or destruction of surrounding tissues. So this pattern supports benign lesions, since maturation with depth is one of the key features that distinguish it from malignant. So until now, who can have the diagnosis for these lesions?
And I guess that could be genital nevus.
Congenital nevus.
Congenital nevus.
Okay, congenital nevus. So it's a good guess. Okay, so our diagnosis is the. Oh, before that, we have another slide here. So special features. You can see here the special features. It's the roundest as eosinophilic glassy globular at the dermoepidermal junctions, and the called caminal bodies. So with this one, can you have another guest? The caminal body is very typical and special for the disease.
I think I forgot that disease.
So with this one is the spitz nevus. It's quite similar to your gas, but it's not a congenital. Like here we have the differential diagnosis. So how we can rule out melanoma or another type of nevus like red nevus or blue nevus. With the spitz nevus, we have the lesion is symmetrical. They contain epithelioids or spindle cells. The pigmentation is variable and it presents the maturation depth. And we see the caminal bodies, which I saw in the previous slide. If it's a spitzoid melanoma, the lesion should be symmetrical with the atypical and pleomorphism cells. The pigment is irregular and it's absent of the maturation with depth, and it has the atypical mitosis. With the red nevus, it has a special feature is the heavy and uniform pigmentations, and the clinical show the starburst pigment with the this is about the clinical. And the blue nevus, it has the prominent and deep the pigmentation in the dermis. So our final diagnosis is the spitz nevus. So now we will review again the features of this one. The architectural features, including its symmetrical, circumscribed, and longitudinal nest. It has the maturation and epidermal hyperplasia. About the cytologist features, we see the epithelial cells and spindle cells in various proportions. The caminal bodies, it may have nucleotibia, but it's not must, and it no or rare leaf the mitosis. So now we go to the second case. The second case is the 35 years old male with lesions on the shoulder. We see here it's the pigmented lesions slightly rise with the irregular edges. The color is variable. It is the central dark brown with the surrounding lighter brown pigmentation. The border is not sharply demarcated and blend into the surrounding skin. The diameter is about 6 to 7 millimeters. So under microscope, we see the asymmetry lesions. The epidermis so elongated of the little ridges here. The melanocytic nest at the dermoepidermal junctions and its proliferation into the superficial dermis. In the dermis, we see the inflammatory a mild inflammatory infiltrate, and the fibroplasia. With higher views, again we see the irregular elongated of the reader ridges here, and we can see some bridgings between adjacent reader ridges. Here we see the bridgings over here and maybe over here. Yeah. In the junctional, we see the nest and also the single. We see some the single melanocytes along the double epidermal junctions. In the dermis, we see the nest of melanocytes present in the superficial dermis. With some evidence of maturation in the deep, we see here in the deep, we see the cell is quite smaller. And we also have the inflammatory infiltrates surrounding the vessel in the superficial dermis. In higher views, again, we see the nest and the single cells located at the dermal epidermal junctions and some cell within the epidermis itself. In the dermis, it contains nest and seed of similar cells. And we can see here the dermis show some feature of solar elatosis. It's the bluish color in the background. We can see here the dense proliferations of cells forming nest, cost, and seed within the dermis. The surrounding stroma show some dermoplastic change, meaning there is a fibrous connective tissues reaction separating the tumor nest.
Can I guess?
And yeah, I have one more slide for the bottom of the lesions. So if you want, you can describe the slide and give me your guess. Oh, I'm sorry. So here is the bottom of the lesions. So now what is your diagnosis? Yeah, yes.
Dysplastic nevus.
Dysplastic nevus. Yes. Yes, that is correct. The one is dysplastic nevus. So about the architecture's features, we have the lentiginous proliferations. The nest vary in shape and size. It has regions of the junctional nest. About the cytologic features, it contains spindle cells and epithelial cells, some nuclear atypia, but not tumors. And they have a lymphocyte infiltrate in the superficial dermis. And the fibroplasia can form the lamella or concentrics surrounding the nest. This disease have many differential diagnoses. For example, we should differentiate with the invasive malignant melanoma. So they have invasions about the typical cells found if in the dermis, and they are lost irregular and so no maturation with lessons. And the melanoma in situ, the atypical cells cast throughout the full thickness of the epidermis. And here, this one we discussed earlier, it's so symmetrical and often aggressive. The cytology is so large and plumb epithelioids or spindle cells, but the lesions usually show maturation with depth. And we also should differentiate with the recurrent nevus and common nevus. Now let's go to the third case. We have the 15-year-old girl with a lesion on her cheek. The lesions here we see it the small, dark, dome-shaped nodule located on the cheeks inferior up to the eyes, and it had irregular, sharp borders. In the lower view, we see here the lesion here is a large, deep dermal nodule that is poorly circumscribed and extends from the upper dermis into the subcutaneous fat. The lesion is highly cellular with a noticeable blue or biscoid background in the center. The overlying epidermis is intact, confirming the mass is primarily in the deep dermal bay process. See, here is all the lesions here. In a higher view, we see the lesions in the deep dermis extending down to and around with the white fast lobular and hair follicle. It contains a mix of dark blue cells, dark purple cells, is the melanocytes, and blue mucins. Maybe it's the biscoid stroma. And we can see the scattered brown black pigments over here. Over here. The high magnification will show the spindle-shaped cells. They are spindle. They are elongated with the dark and irregular, some irregular nuclei embedded in the dense pink fibrous stroma. They are collagens. And numerous pigment, melanin pigment, scattered throughout the tissues. So we can have the diagnosis for these lesions.
Is it blue nevus?
Yes, exactly. This blue nevus. So now we talk a little bit about the immunostain. So with the melanocytic lesions, we have as SMB45. The target is the melanogenesis pathway proteins. So the typical is for the benign device, its staining is strong in superficials, but not in the deep. With the Ki67, is the proliferation rate in the benign device, including the blue or split device, is usually low, typical less than 5%, and is often confined to the superficial or junctional zone. With the PREM, it diagnoses the highly sensitive. It's usually so the negative in benign device or weak or focal. With melanoma, it's often diffuse positive in primary and metastatic lesions. S100 and SOC10 is the diffuse with all lesions, including benign or malignant. And melan A is the similar. So with the table, this table shows the summary of the immunostain and molecular features that help we differentiate split nevus, split melanomas, sphenoid melanoma, red nevus, blue nevus, dysplastic nevus, and melanoma. In spitz nevus, the HMB45 stain only superficially and fades with depth. The key 67 is low, and the SRAS, the mutation is common. With the balloon nevus, its variable is the in HMB45, and it's so rare mutations, so it's very low in Ki67. And the last one is the disparatis nevus. So the mild increase in Ki67, the superficial HMB45, and the BRAF mutation is common. So thank you for your attention. So
Yeah, thank you, man. That was awesome.
yeah, thank you so much.
Does anybody have any last questions for Van? Anything that happened throughout the presentation?
I have one question, but before I ask, I thank Dr. Van for a really nice presentation, because the melanocytic lesion is frightening me a lot, and I always make the wrong diagnosis, nearly. And my question is about the Ki67, that you say that in melanoma would be high, and in other melanocytic lesion is low or mild, and uh, can you tell a cutoff, and what proportion that we could say the Ki67 is high or low? For example, if I have a Ki67 rate about 30%, is it high or low?
So I think okay, let me see. So because like Ki67 is the marker of the active tumor, so it depends on the type tumor. I just remember that in the lymphoma, we call it low if it's the less than 40%, right? In the lymphoma, it's less than 40%, and with the lymphoma we call low is less than 10%. 10%. If it's from 10 to 30, is the moderate, and it's high if it's the more than 30. So in this is for melanoma, so it depends on each type of tumor. For lymphoma, it's different. For breast carcinoma, it's different. Yeah.
Awesome. Do we have any other questions for Van?
Actually, I need Dr. Asabeji here.
I have a questions. So I saw that you have BRAF and HRAS mutation. So do we usually use this stain in diagnose, like in reality?
Yeah, I think in US it's quite common, but it's not in Vietnam. In Vietnam, we don't have the condition to to do this. Yeah, I have reviewed some the paper from here. It's that they also do this test for the benign lesions. Yeah, I'm not sure about it, but I think it's quite common in US.
Yeah, I know BRAF is pretty common in the US in the Derm setting, and some other settings as well, but it's often a send out test and it's not in every single laboratory.
Awesome. Well, if there's no more questions, again, thank you so much, Ven. That was a great presentation.
Thank you so much.
Dr. Isadbeji actually said that she was trying to join a couple minutes ago.
That's great.
So I'm just not sure if she'll be on, but because otherwise I think that's all we have prepared for today. And if nobody else has any other questions, or if Dana has something to share.
Nope, just gonna say, sorry about the shorter session. We had a little bit of last minute disasters, guys, but thanks for doing a great job and showing up. And then please note that the evening session has been moved. Can you remind everybody, Felicity, when that is?
Yeah, the evening session will be next Wednesday at 7 p.m. Eastern time. So I'm not sure what time that is for each of you individually, but we'll send out an email about that as well.
Thank you so much.
Absolutely.
Thanks so much, everybody.
Yeah,
Thanks,
thank you so
everyone.
much.
Have a good rest of your day or night.
Thank you.
Bye.